So we'll discuss iron deficiency anemia and its differential diagnosis here. It's a very oft repeated question for you, no matter whether you're giving an exam viva or you're appearing for an exam. And again, it could be a college exam, it could be a competitive exam. You'll also see this situation commonly in your life as a doctor, right? So it would do well for us to understand this topic nicely. Okay, so let's first look at how we classify these anemias, this group of disorders, right? So anemias that produce a normochromic, normocytic blood picture on the peripheral smear, normochromic and normocytic picture on the peripheral smear. I know your doubt, you're thinking of iron deficiency, I'll just explain that. With a poor proliferative response. How do you assess proliferative response to anemia? A low reticulocyte response, right? Retic is short for reticulocyte. And how do you objectively measure that? A reticulocyte index of less than 2.5. I'll just explain what reticulocyte index also means. So when you have these two criteria met, a normochromic normocytic anemia and a reticulocyte index of less than 2.5, you're dealing with the group of anemias called hypoproliferative anemias. So I was saying I'll come back to iron deficiency. So early in its course, iron deficiency will cause a normochromic normocytic blood picture, and late in the course cells become smaller with lesser amount of hemoglobin, that is microcytic and hypochromic RBCs, right? Besides this, anemia of inflammation. Previously this was called anemia of chronic disease. Anemia of inflammation is another common cause of hypoproliferative anemias. The marrow doesn't respond appropriately to the severity of the anemia, right? It's also called anemia of chronic disease, right? Endocrine conditions with a low metabolic rate like protein energy malnutrition, like hypothyroidism, are also associated with a poor reticulocyte or poor bone marrow response to the anemia. Myelophthisic anemia is an anemia that occurs because of bone marrow infiltration. Often this is either fibrosis or infiltration by a malignancy, right? So these four together constitute the hypoproliferative anemias. The two parameters required for that distinction, for giving the anemia that name, are normochromic normocytic RBCs and a poor marrow response, right? Let's go to reticulocyte index. The bone marrow responds to any anemia by producing more red cells, right? And those new red cells are reticulocytes, right? Now, what happens is that in an anemia, because the absolute RBC number is low, when there is a large production of reticulocytes by the marrow, you might have a high reticulocyte percentage relative to this number. Because the RBC number is small, the retics which are being released by the marrow can appear to be in a very large percentage, right? In such a peripheral blood picture, in such a peripheral smear. How do we compensate for this change? How do we compensate for this artifact? Is that we correct the reticulocyte percentage for the severity of anemia. That means, let's say that you get a reticulocyte percentage of 9%. The patient's hemoglobin is 7.5. We correct it for expected hemoglobin, and that gives us the corrected reticulocyte count, right? So there are two corrections. The first correction is for severity of anemia. It's a multiplication with the patient's hemoglobin relative to the expected normal hemoglobin at that age, right? The age and sex of the patient, right? Sometimes a second correction is required, and that's when you see that on the peripheral smear there is a large number of polychromatophilic RBCs. So what happens is that the marrow often responds by releasing these cells prematurely into the circulation. And when that happens, then these retics persist in the circulation for more than one day. Now, what you're doing with the reticulocyte count is assessing daily marrow response. The bone marrow response on a daily basis is what you are measuring. So if this is the case, you have to correct the this calculation here, the corrected retic count, for the longer duration of persistence of these reticulocytes in the peripheral circulation. So typically what you would do is divide this corrected reticulocyte number by 2. The first correction for the severity of anemia, and the second correction for the longer persistence of prematurely released polychromatophilic RBCs in peripheral blood. If you don't see these cells on peripheral smear in an anemic patient when you're doing a reticulocyte index, if you don't see a large number of these cells on peripheral smear, this correction is not required. Okay, so but if they are seen, you divide the percentage by 2, and that gives you the reticulocyte index, right? So reticulocyte index is a correction of the reticulocyte percentage for 2 variables: 1 for the severity of anemia, 2 for the longer life cycle, for the longer persistence of reticulocytes in peripheral blood, which is typically more than a day, which is what gives you the factor of 2. Now going to iron deficiency and its differential diagnosis. So those are the anemias that you will typically be expected to differentiate iron deficiency anemia from, and most typically it's going to be iron deficiency versus anemia of inflammation, right? So I'll come to how to get your differential correct. Thalassemia will also cause a similar blood picture with low retics. So will sideroblastic anemia, and those of course are the normal values, correct? Now, before we delve into how to distinguish, let's look at what each of these represents, right? So the smear, of course, is smear itself. What does the serum iron represent? So the serum iron in the serum is transported bound to transferrin. So the serum iron concentration is a reflection of the amount of iron that's bound to transferrin. It's not the same as transferrin saturation, mind you. This is something else. I'll just come to that, right? So what is serum iron representative of? It is representative of the iron bound to transferrin in the serum, right? What is TIBC representative of? It's representative total iron binding capacity. What's the protein that's binding iron is apotransferrin. So circulating transferrin concentration is what's given by the TIBC. The total iron binding concentration represents circulating transferrin concentration. Transferrin saturation. So now the entire transferrin in the blood, in the serum, the amount of it that's saturated with iron, that's the amount of iron available to tissues. So that's what transferrin saturation represents. It represents iron supply to tissues. Okay, ferritin reflects iron stores, right? So all those four individually are questions for you. Serum iron represents iron bound to transferrin. TIBC represents circulating transferrin. Transferrin saturation represents iron supply to tissues, and ferritin, of course, you know that already, is reflective of body iron stores, right? So all those are potential questions for you, right? Now let's look at how to distinguish these two entities. Especially let's look at iron deficiency anemia versus anemia of inflammation, right? So the smear in both of these entities is more or less the same. Normocytic normochromic in the early stages and becomes microcytic hypochromic in the late stages, even for anemia of inflammation patients, right? So we know that this won't help distinguish these two entities. The serum iron is low in both, right? So it's less than 30, less than 50, it's low in both. Again, it will not help to distinguish unless the serum iron, of course, is very low and 10. Then you can say that's more likely to be iron deficiency than anemia of inflammation, although again it is not distinctive, right? What is distinctive is the TIBC. The total iron binding capacity is higher in patients with iron deficiency anemia and is low in patients with anemia of inflammation. So that is definitely one distinguishing feature between these two entities. Transferrin saturation again is low in both entities, right? So again, that's also not a distinguishing feature. Ferritin is. So body iron stores are low in iron deficiency anemia. They are normal in anemia of inflammation. So I'll just come to pathogenesis of anemia of inflammation. It is basically a poor response to erythropoietin. It is basically a poor release of iron to bone marrow, right? So the body iron is normal, but marrow doesn't get enough of it, and the marrow responds poorly to erythropoietin, right? And of course, hemoglobin electrophoresis would be normal in both entities. So the only two lab parameters that distinguish iron deficiency anemia from anemia of inflammation or anemia of chronic disease are the TIBC and serum ferritin. Please remember that. Okay. Moving on. Red cell protoporphyrin. You might get a question on red cell protoporphyrin. It is one of the intermediates in the heme synthesis pathway. You have probably read about this when you have read porphyria. So its levels will be elevated wherever there is a heme synthesis abnormality, right? So iron deficiency of both types, absolute and relative. You understand absolute iron deficiency. Now, what is relative iron deficiency? Absolute deficiency is iron deficiency anemia. Relative iron deficiency, where iron is available in the body but not available for RBC production, and that's anemia of inflammation. So, red cell protoporphyrin levels will be elevated in both IDA and anemia of inflammation. That test will not help to distinguish one of these entities from the other. While lead poisoning also will be associated with high red cell protoporphyrin levels, right? And then there's transferrin receptor protein levels, which reflect total erythroid marrow mass. Transferrin receptors are present on all cells of the body. All cells of the body need iron, right, for normal function. They are maximally located. Their concentration is highest on RBCs, and therefore, transferrin receptor protein levels. Some of these proteins, they're soluble. They get detached from the main protein complex on the red cell membrane, on the bone marrow cells, and they are released into circulation. So their concentration reflects total erythroid marrow mass, right? So this will be elevated only and only in absolute iron deficiency. So that is a test that will distinguish iron deficiency anemia from anemia of inflammation. So those are again all MCQs for you right there. Now, what's anemia of inflammation? I was saying I'd tell you its pathogenesis very quickly. There are three important cytokines there. The first is interleukin 1. It decreases erythropoietin production in response to the anemia, and it reduces the response of the marrow to that erythropoietin. So production of erythropoietin is reduced and response to erythropoietin is poor, and that's because of interleukin 1, right? Then, of course, there's tumor necrosis factor, and TNF acts through interferon beta, and this also suppresses the response to erythropoietin. And last on that list is hepcidin. You've read about hepcidin when you've studied iron absorption from the GIT, and it reduces iron absorption. Hepcidin inhibits iron absorption from the GIT and iron release from storage site. So therefore, you see that there is a combination of poor response to erythropoietin and poor availability of iron from the body tissues, from body stored iron stores to the bone marrow, right? So that it sums up the pathogenesis of anemia of inflammation, right? That's another question right there for you. Okay, fine. Going to the other two entities that we have not discussed yet, sideroblastic anemia and thalassemia. Again, you will notice, see, the serum iron in both of them is normal to high. The total iron binding capacity in both is normal. The transferrin saturation is high. Transferrin saturation is high. When this is more than 50%, it implies that there will be a high delivery of iron to non-erythroid tissues, right? So this is reflective of possible iron toxicity to epithelial tissues, right? And sideroblastic anemias are refractory anemias. So that means they won't respond to hematinic therapy. They won't respond to iron. They are refractory. They have an excess of iron in the bone marrow, but still nevertheless have hypochromic RBCs. When you get that combination, how do you know there's an excess iron in the bone marrow? When you do bone marrow, this is the bone marrow stain, and you'll see these cells here, right here, are sideroblasts, right? And they're loaded with iron. And iron is typically arranged in a horseshoe manner around the cell, right? In a ring-like or horseshoe manner. Siderotic granules is what you'll see, and that reflects that there is excessive iron in bone marrow. And on the peripheral smear of this patient, you get hypochromic RBC. So when you get that combination, you're dealing with sideroblastic anemia, right? And how do you establish conclusively whether it's thalassemia or sideroblastic anemia? Of course, with hemoglobin electrophoresis. Remember that hemoglobin electrophoresis can be normal in patients with alpha thalassemia, right? Okay, so I told you about how a high transferrin saturation and a high serum iron reflect an iron overload, right? So very quickly, let's discuss what we have just discussed and go over a recap, right? So we discussed iron deficiency and anemia of inflammation. We said that in both the serum iron and transferrin saturation would be low. What would be different are the TIBC and the serum ferritin. The TIBC is high in patients with IDA and it's low in patients with anemia of inflammation. The ferritin is normal in anemia of inflammation. It is low in patients with iron deficiency anemia. The transferrin receptor protein is high in absolute iron deficiency. Red cell protoporphyrin is high in both absolute and relative iron deficiency. So it will be red cell protoporphyrin will be high in both iron deficiency anemia and anemia of inflammation, right? Then we discussed thalassemia. You'll see target cells on the peripheral smear. You know what target cells look like with a zone of intermediate pallor. This is what a target cell will look like, and you make that diagnosis on hemoglobin electrophoresis. Sideroblastic anemia, the combination of hypochromic RBCs on peripheral smear and ring sideroblasts, which reflect excessive bone marrow iron on a bone marrow aspect, right? And we discussed the pathophysiology, what are the various cytokines, what they act through, and they reduce the response, the release of erythropoietin, the response of the marrow to erythropoietin, GI iron absorption, and release of iron from stores to the bone marrow, right? That is that, right? And we'll end on that note. Those who were Nietzsche, that famous philosopher, said that those who were seen dancing were thought to be insane by those who could not hear the music. Well, I hope you're hearing the music. I am, and we dance our way to cracking the exam. Bye-bye.